Hello, my name is Liz Heileman with HIV and Hepatitis.com, and we're here at the 20th Conference on Retroviruses and Opportunistic Infections in Atlanta to learn about some new data about HIV, and new for CROI in the past couple of years is a discussion of hepatitis C as well, which we'll be focusing on today. And I have with me Cami Graham from Beth Israel Hospital in Boston, Dr. Kenneth Sherman from the University of Cincinnati, and Dr. Kristen Marks from Cornell. So first, would one of you like to sort of summarize some of the studies we saw here? We saw some studies of some of the new direct-acting antiretroviral agents used in people with hepatitis C alone, which we call monoinfected, and some data about these new agents in combination with pegylated interferon and ribavirin for people with both hepatitis C and HIV, we refer to as co-infected. So. You want to give us your sort of thoughts about what you heard at the meeting?
I will get started with that. First, I want to emphasize what you said right at the beginning, that more and more hepatitis is becoming an important component of this meeting, and there's clearly an effort and an interest to get out messages about hepatitis to the infectious disease community that traditionally manage patients with HIV infection. But to expand that, there's a tremendous need to have increased numbers of providers to manage the large bolus of patients, both mono-infected and co-infected, that we think we will be seeing across the United States, across the world in the next few years. At this meeting, I think we have continued to see some important data regarding both extensions of current therapy, how to use treatments that we have, the addition of newer direct-acting agents to peg interferon ribavirin, as well as the emergence of data. It's been a process now for the last few years of the interferon-free regimens that combine various medications, but without the use of interferon for the effective treatment of hep-c. And not only globally can we say that these treatments appear to be better tolerated overall, but they have been associated with decreased duration of therapy and very high rates of sustained viral response, which is the word that has been used historically to really mean the cure of hepatitis C infection. So I think that it's worth mentioning a couple of those agents and the data that we've seen at this meeting. We saw a couple of studies with sofosbuvir, and perhaps one of you might comment on those studies.
All right, just for background, sofosbuvir is Gilead's hepatitis C protease inhibitor. It's formerly known as GS7997, which is how some people may know that. So, please.
On Monday, we saw for the first time the data of its use with another Gilead agent, which now has the name ladipsavir. I think I said it right.
And that would be formerly known as GS5885.
Yes, with ribavirin, and the presenter did a nice contrast of the results from the dual therapy, so the sofosbuvir with ribavirin alone versus using the triple combination of the two direct-acting antivirals with ribavirin. And there were small studies, but there was actually two arms. One included treatment-naive patients, and one included null responders, which is, are the sort of hardest to treat traditionally patients.
Which are people who have tried interferon therapy before, essentially, and didn't achieve a cure.
Didn't work. And when those patients were studied in the past with sofosbuvir and ribavirin, those patients, for 12 weeks, the treatment had very high relapse rates. They were suppressed on treatment but relapsed. Right. And so the addition of the third agent, we saw much higher SVR rates, actually 100%. Granted, small numbers of patients. I think it was 10 in that arm. You can correct me if I'm wrong. But that was very exciting. And also the treatment naive similarly had 100% SVR4 and 12. So
Certainly something we'll all be looking forward to see what
that was one of the most exciting
goes forward.
presentations for me.
The other study that we saw presented earlier today from Dr. Osanusi at the National Institute of Health was the SPARE-1 trial. And this study is particularly interesting because it represents a closer representation of the real world of patients that we see. The NIH set up a phase 2 study in an inner city population in the Washington, D.C. area and treated patients with sofosbuvir plus ribavirin using a randomization to a lower dose versus a standard weight-based ribavirin dose. And a quarter of the patients had advanced fibrosis and cirrhosis. The majority were African American. So this represents the kind of population that, again, is very real world and is somewhat different than what typically enters the drug registration trials.
These were almost all or all people that were being treated for the first time?
That is correct. Right. They were treatment naive patients. And the study demonstrated very good results, not the 100% seen in small groups of perfect patients, but very high response rates. Virtually no adverse events or drug-related side effects seen, and at least some evidence that the higher dose of ribavirin might be needed in this interferon-free regimen.
Great. And you mentioned one of the other agents is faldaprevir. Did anyone?
Well, I was going to comment. So,
please.
It's not going to be clear when we can get rid of interferon in all patients. And so 2 important studies, faldaprevir and then another new protease inhibitor, cimeprevir, were both looked at with pegylated interferon and ribavirin in HIV hepatitis C co-infected patients. And I think one thing that really struck me was the results in these 2 studies. There were different studies. Cimeprevir actually looked at treatment-experienced patients as well, but the results looked almost identical to what we've seen in the hepatitis C mono-infected patients. So you're now having people say, we're not really sure HIV has that much impact on responses. Right. And compared to when we just had pegylated interferon and ribavirin, with much, much lower cure rates in the co-infected population, I think this is a very transformative sort of idea that maybe HIV is not going to be a barrier to cure like it was before the direct-acting antivirals.
And I think that something similar was seen with boceprevir and telaprevir, which were the first 2 protease inhibitors, and they're not as convenient and not as tolerable as the new ones, but they also had similar response rates, and if I remember correctly, the side effects weren't appreciably greater in co-infected people, which is what there'd been some concern that might be the case.
If anything, I think the side effects have been lower.
One of the important things as an HIV provider about the faldaprevir presentations were they did show the drug interactions with darunavir, which up till now I haven't been able to use with co-infected patients, although boceprevir arguably you could. Usually I'll do that as part of a study if I'm doing that. But they showed basically that the faldaprevir levels are lowered by darunavir, as one might expect.
It's great to see some of the companies doing the studies
doing
these
it
drug
before they did
interactions
their phase 2.
before they need to see them.
And it didn't appear any difference in response based on the use of that drug. So it's an important.
And you'd mentioned, Dr. Sherman, about the expected sort of influx of new patients, and I know the public health authorities have sort of recently recommended that everybody in sort of baby boomer age group be screened. Can you talk more about why that's important and what you think that will result in?
Sure. So for the last decade and a half at least, we've been operating under a paradigm of patients with risk should be screened, and the choice of determining who's at risk and determining who should be screened has been in the hands of mostly primary care physicians who overall it appears, have elected not to screen patients routinely for hepatitis C. And data in various types of high surveillance areas actually suggests that we're missing or have missed many opportunities, that someplace between 50 and 75% of all patients with hep C in the United States have not been tested and don't know that they have hepatitis C. In the last couple of years, there's been an effort by the CDC to try and identify newer strategies that might help us determine a better way to identify those people. And various modeling studies have suggested that there is a peak incidence or peak prevalence group that exists between those people born in 1945 to 1965, which corresponds to periods of both a high risk in the blood supply for women who received transfusions and in that period of time, and those who experimented or in some cases used for longer term injection drugs. And so the rate of positivity in that cohort is elevated, and based upon various models that tell us the cost effectiveness of doing this screening, the CDC has now promulgated a concept that there should be at least once in your life, every person who was born between 1945 and 1965 should be tested for hep C. That will not identify everyone who has hep C, but it will identify something over 800,000 people that potentially could then be treated and hopefully with these newer agents taken to cure. Now, there are still many hurdles that remain, and perhaps Cami would like to address some of those.
Yeah, I mean, this is really important. If society chooses to try to identify these baby boomers, which represent about 75% of who has hepatitis C, the CDC estimates we'll save 120,000 lives. And that's estimating that not everybody will be treated, and so this is an opportunity to really make an impact. But what we're trying to understand is, how do we get that word out? How do we make sure that people understand, that they do need to be treated? How do we increase the capacity of care providers so they have a place to go, to be evaluated, to be treated? So there's a lot of logistics we're going to need to work out. But I think, the most important step was really getting a very clear, simple recommendation from the CDC, and they did a nice job at this meeting describing that to us.
So going forward, I guess you sort of started to touch on this, but what are our hopes for the field in the next maybe 5 years going forward? I know we're going to start to see some of the new direct acting agents be approved, perhaps as early as the rest of this year, and going forward, we're going to see the interferon-free combinations. So what are your projections?
I think
Start that looking
I'll
at
start
crystal
that.
ball, Kristen.
I'd like to see less toxic, shorter duration, with drug interactions that are manageable and well defined. Would be my goal. Was that the answer to the question? I'm not sure. That's was the question you asked.
Yeah.
Well, I think that actually the next couple of years are going to be tough, because we're going to see the beginning of this transition to newer drugs, and at least in certain settings, clearly identified interferon-free regimens. For example, the genotype 2-3 patients will probably be the first to be approved in an interferon-free regimen. But I fear that there will be a belief that will automatically apply to everybody. Right. And it's going to cause actually a great deal of confusion among the community that identifies these patients and the patients themselves. over the next few years, I think we'll start to see the availability of more interferon-free regimens, but at the same time, the next primary wave is actually going to include treatment with interferon for genotype 1 patients. And yes, the treatments will get better. For example, cimipravir will hopefully be coming up for evaluation by the FDA within this upcoming year. But and it's once a day, and there's less drug-drug interactions, but it's still with peg interferon and ribavirin.
Right.
We saw some data today on interferon-free regimen with cimipravir and sofosbuvir, and that's really exciting data, but that's still early phase 2 data, and again, that's going to be, by the time it gets through phase 3 trials, another couple of years down the road. So if anything, I think the next 2 years there will be confusion. Patients who have hep-c are going to need to make sure that they have conversations with their healthcare provider. And there's a duty of the healthcare providers to kind of be up on what is happening, what is changing, and what is coming, or else we're not going to be able to properly guide and advise the patients about do this now versus wait another year, go beyond that. And finally, there's still a giant variable in this, and that's the cost of these medications. The current ones we have are very expensive. The next generation is likely to be expensive, though we don't know anything about pricing at this point. And we have to decide as a society, are we paying for these cures that, as Dr. Graham said, will save lives, but there has to be a societal will and a societal commitment to do that.
Okay, well, thank you very much. I think we're out of time, so thank you for joining us, and I think we have an exciting period ahead of us in the world of hepatitis C.